Thank you, Ajay, and for inviting me to be part of your course, and to the AIOS members, good afternoon. So we've already been, I think, told by now that we know there are two types of macular edema: the center involving, which requires anti-VEGFs; the non-center involving, which classically does not require anti-VEGF, and one does not prescribe anti-VEGFs for them. You either give good control, you can do a gentle laser, or as Ajay is doing, sub-threshold laser can also be done. So it's basically the center involving edema which troubles us a lot because the vision drops. And there are various definitions. We usually take it over 300. If the edema is crossing into about the 300s, or even to 275 for that matter, 250 is considered normal micrometers in the central 1 millimeter zone. So the role of anti-VEGF is very paramount. Okay. So this is the center involving edema on the left, and this is the non-center involving edema. You can see the cystic space is a little outside. The foveal dip is maintained. And also look at the outer bands, and you see the nearly present. There's a small serous detachment over there. So these kind of patients require anti-VEGF therapy. So the role of anti-VEGF is, because of the VEGF upregulation, you've got to counter it. There's a breakdown of the blood-retinal barrier. It's a preferred mode for first-line management for center involving DME. Prevents visual loss, improves vision, in fact, unlike laser. And the choices are with you. Of course, new ones are coming up, for which I'll just tell you a little bit in the last slide. So anti-VEGFs, we've got a lot of questions to ask us ourselves, that when to initiate, which treatment to use, which anti-VEGF to use, what regimen, the monthly pair and or treat or extend, efficacy, cost effectiveness. So this resolve, the three studies which I'm going to tell you, the RISE, RIDE and the resolve study, they were basically studies which checked the 15-letter visual acuity gain. So the percentage visual acuity gain, you can see beautifully, has been given the phase 3 randomized controlled trials of RISE, RIDE and resolve. All three showed the sham had lesser visual gain of 15 letters, the ranibizumab had the maximum visual gain, and the ranibizumab 0.3 and 0.5 had a little, nearly the same or even less. So what it said was 0.3 ranibizumab was safe, and safety trial was of course done before. This is the efficacy trial. So efficacy usually the phase 3. Safety is usually phase 1 and phase 2. Any trial you conduct, you first have to do the safety, get the safety approved by the ethical committee, and then you go on to the efficacy trial. Till such time the ethical committee doesn't clear it, you cannot go on to the efficacy trial. So this holds true for all randomized controlled trials or all studies which we've done. Even at AIIMS, we find that we have to go through a very rigid ethics committee who have meetings after meetings for that. So anyway, they went through it, and they found that this was the most effective. So they said that ranibizumab, one of the drugs anti-VEGF recommended for DME, in this slide tells you that ranibizumab was very effective, 0.3 milligrams. For laser treatment also, they found the READ and the RESTORE showed that the focal grid visual acuity 15-letter gain was 9% versus 32 and 22.6. So even versus laser, versus sham versus laser was much better. So therefore, it is recommended that as compared to laser, as compared to sham, you've got to give anti-VEGF first. That was the first slide which showed you that some conclusions we derived. This is a OCT and a octa of the same patient. It shows the void. These are the void spaces. These are the fluid void spaces, and these spaces are actually the ones which have the edema. And once the edema goes down due to 3, we've given 3 monthly injections. We usually give a loading dose of 3 to 5 for diabetic retinopathy, diabetic macular edema, unlike the AMD where you give 3. So then the edema goes away. So more of a OCT, we follow up on basis on OCT. Initial maybe a fluorescein is required, but for follow-up injections, you just need an OCT and the OCTA if required. So this is the second slide which will tell you a point towards what you should give. So this second slide is the protocol I. The drcr.net is a diabetic retinopathy clinical research network of about 50 hospitals, all within the US. They have a network of patients which they get together, and then they see the outcomes. And the outcomes were greater than 15 letters again at 2 years. Sham plus laser or just laser, that means had 18-letter visual gain, and ranibizumab with prompt laser within 1 week, that is combination therapy, 29, and 28 for a deferred laser. And this was 2-year study, 2-year conclusions. And the fourth was using steroid with laser, was 22. So what they concluded in rough was that the ranibizumab with laser, whether deferred or prompt, did very well, and they extended the study from 2 to 5. And the protocol I 5-year study shows that maximum visual gain in the ranibizumab deferred laser group. That may see that what they tell us is, from the point of view of these questions which we are asking ourselves, is that the ranibizumab was effective and laser could be given later at a deferred period. This was the second. Bevacizumab also is very effective. It's an off-label drug, but still one of the trials was done by the drcr.net, the protocol H. Where they found it a greater reduction in central subfoveal thickness and at 3 weeks, and no difference between 1 and 2.5. So that was very good that the 2.5 was not recommended, because this drug can cause stroke. I told you it's a large molecule. In the morning also, this is a very large molecule. This stays in 20 minutes. 20 days is a half-life in the bloodstream. So though it's an economical drug, can be easily used. The patient has to be, if he's got a cardiac or a recent stent put, or at least that's what I do. If the recent stroke or a recent CAPBG or a recent stroke, I send him off to the neurology people in the CN center of AIMS. I just tell him to disappear, get all the clearances and come back. Once he comes with the clearances, then I'll give the anti-VEGF. I don't want to play with the fire. It's better to get a clearance of the recent onset. It's an old MI, maybe 5-7 years back, and he's well controlled. There's no need to stop anticoagulants also, we can give it. But for surgery, we do stop clopidogrel, we don't stop ecosprin. That's different. So BOLT was a bevacizumab, another group study which showed that was more effective. So aflibercept is a third drug which has been studied, the Da Vinci and the Vista Vivid. So the Vista Vivid showed, I'll just come straight to the most important studies of the aflibercept group for DME. This showed that 4 weeks or 8 weeks, the dose was, the effect was the same versus laser, and they showed that the sustained anatomical functional acuity with aflibercept was more versus laser, and efficacy was similar. That was the most important thing. Is the 2Q4, that is, you give every 4 weeks, or whether you gave it at every 8 weeks. This is 2 milligrams of of aflibercept at 4 weeks, 2 milligrams aflibercept at 8 weeks. The effect was similar. So they said you can even give it at 2 bi-monthly dose. So sometimes I find it's useful to give it very severe edema even monthly. So it's no hard and fast rule that you have to give it at 2. Sometimes at 1, sometimes even later, but generally it's 1 to 2. So this is a little potent. It's got a very strong binding anti-VEGF binding capacity, 140 times more than ranibizumab, but that doesn't make it 140 times more effective. So this is the third very important study which will tell us about the 3 drugs which are right now being used all over the world. The aflibercept 2 milligrams, the ranibizumab 0.3 milligrams, and the bevacizumab 1.2 milligrams. Now look at the 1-year mean change of ETDRS letters. 13.3 mean, 11.2, 9.7. Okay, is this the best? No. If vision is better than 618, if his vision is 6 to 618 and he's got DME, then there's no difference between the 3. If the vision goes below 618, then they say ranibizumab goes very much behind, but between the 2 superior drugs, that's what they say. The study says the aflibercept was slightly superior. Actually, if you see the letter acuity, there's hardly any difference. Ranibizumab has done extremely well with even 0.3 milligrams. So it's not that ranibizumab is not as good as aflibercept. So this is the conclusion from protocol T. So these tells you about the various anti-VEGF. This is a very interesting. From protocol T, a post hoc analysis was done, and this was done at 5 years. They found they wanted to show that whether early response, a good response at 6 months, was it predictive of long-term destiny. A less than ideal response at 12 weeks, 3 months, did not impede substantial visual gain at 2 years. That means a less than poor patients who did not respond so well to anti-VEGF in protocol T with any of the anti-VEGFs does not mean they are basically condemned to have poor visual acuity afterwards. In fact, a large number of eyes, for a large number of eyes. Also, the majority of eyes with less than 3-letter visual gain at 3 months had a final 5-year visual acuity, a very good final visual acuity at 2 years. So what they wanted to say is that initial visual acuity, letter acuity also does not play a role. So you have to keep on treating, and you will probably end up with very good visual acuity. So come to the regimen, you have a fixed treatment regimen, you have a as and when required treat and extend by 2 weeks. So retain and the restore tried the treat and extend, which was inferior, they found it inferior. The drcr.net, which is the most important trial going, which is using the PRN dosing. So persistent DME, you can switch anti-VEGFs combination, you can give rescue laser, or you can give surgery. Rescue laser means you can do it targeted or grid or focal. This is a patient who's got got PDR and he's uncontrolled, he's got a chronic kidney disease. Such cases we don't inject fluorescein, we just get the octa done. So these are the kind of cases you can give the anti-VEGF, but post multiple anti-VEGFs he's not responded. So this is the advantage of imaging, that even if the patient has not responded, you might like to switch the antibiotic or go straight to steroids or that kind of therapy. I'm just ending. This is the protocol S, the 3 important protocols which will tell you about which drug to put. The IT I've told you, the S is for the PDR. Here they found ranibizumab was superior at 4 weekly given versus prompt PRP, and ranibizumab at every 4 weeks. Ranibizumab was found to be non-inferior and a reasonably good alternative. The superior visual acuity, lesser field loss, lesser vitrectomies. But the patient has to come back for follow-up. Lower incidence of DME with ranibizumab. PRP was given whenever there was a failure of anti-VEGF therapy. So what they said was in PDR eyes also anti-VEGF works. So these are kind of eyes where you have PDR also. You can give the first shot or give 3 shots of anti-VEGF, and then you need lesser burns, targeted laser, and much better. So this is what I would think that if you have PDR eyes, like this patient is similar, the fundus and the FA, and you can see after 3 doses of anti-VEGF, but you also modify the protocol S to adding this laser to it, and then you find when the neovascularization suppresses down, then you can probably get a better result with the laser which you give, and much less laser. But on the contrary, a recent patient who had PDR, a little bit of traction, by mistake I think I gave an anti-VEGF, and his PDR suddenly increased and he went into a kind of a TRD involving the macula. So I've just operated him before coming. So it's not that if the traction is there, if the macula is getting threatened, then don't give the anti-VEGF in PDR. So I think PDR has lots of loopholes. It has to be patients who are not having traction, not involving the macula or threatening the macula. It should be patients who are ready to come back for follow-up. And you have to add laser. You can't just say I keep on injecting ranibizumab or any anti-VEGF for PDR patients. So newer advances, this is the last and the most important slide in the last 5 seconds, 10 seconds I'll tell you. Brolucizumab is a single arm antibody. It's undergone phase 3 trials. It's found to be superior to aflibercept. The Hawk and the Harrier trial I'd like you to read. It's got very encouraging results. They're going superior to it. And the ABC power is a very, it's a DARPin, it's like a protein, antibody protein, and this binds, it's a very potent VEGF binding. So ABC power is also going to come. This is Allergan, and this is Novartis, the same people who got the ranibizumab. So the third most exciting revolution which is coming is the angiopoietin Tie2 pathway. This is the pathway which controls inflammation in the retina. And this pathway controls inflammation elsewhere also. Disruption of this Tie2 pathway causes inflammation, and then you have to give anti-VEGF, VEGF releases there. So there is going to be a revolution that how to affect this pathway by various drugs. So these are 3 things which are very important: the brolucizumab, the ABC power, and the angiopoietin Tie2 pathway. Thank you so much.